talk about pain. How do I approach pain in my clinic on a daily basis? And I do see a lot of patients that undergo or have a lot of pain symptoms, and a lot of times it's been chronic, been going on for a long time. So, kind of, how do I approach that, and what do I do? Well, I think the first thing you have to do is to make the patient feel comfortable. So, number one, I make all these, social media videos. I try to create all this content because I want people to have, number one, to have an idea of a direction to go if they're having pain or they're having a rehab condition, orthopedic condition, something rehab can help with. But the other thing is also letting them know kind of how I approach things and how I take care of things here at my clinic, because that's also for potential patients. That's kind of how I started originally, was to give you an idea of what to expect. What kind of things do you expect? Are you going to come in and do you have to go straight to exercise? And are you going to come in and are you going to get some manual therapy and massage and modalities, forever? Those kind of things. So that's the biggest thing, is I try to make sure up front that patients know, kind of my approach and how I kind of go about dealing with patients that have pain. And when you come in, the first thing we're going to do is a pretty comprehensive evaluation. Now, my evaluations can be pretty lengthy. It could be up to 2 hours, including treatment. We just try to go through all of your questions or all the patient's questions, make sure that they're fully, anything they don't know, make sure they're fully aware of all these different things. I go over their imaging reports with them, because a lot of times, you have some physician offices and all that will go over in depth the imaging results, and then you have others that will tell a patient, oh my goodness, this is this and this is terrible, and the patient leaves. And when they come in to me, they're very, anxious and nervous, and like, my goodness, I've got spondylosis, which, a lot of times they may get the name wrong, because it's a lot of very lengthy names to a lot of this stuff, right? And you're like, okay, well, 70% of other people over the age of 40 have whatever this condition is. And of that, maybe 60 or 70% are asymptomatic, don't even know that they have it. Um, and so I think a lot of times it's just poor communication, explanation from your primary care or your specialist offices, a lot of times, to really convey that information to the patient. Now, I know a lot of times, maybe they have to kind of juggle their time with other patients, because they're seeing everything maybe in a primary care setting, from a head cold to, to shoulder pain or neck pain to all these different conditions, right? Other issues with the systems in the body. So they may not have time to go over a lot of those things. And sometimes they may not know. Honestly, that's why they refer out to other specialist people that take care of those kind of things. So I really try to go through all the imaging, because I think that's important to make sure the patient's aware of what the imaging says, and also to assure them that, honestly, based off on a lot of research, the imaging does not always match your pain symptoms. I mean, I had a patient a while back. This is a great example. The patient came in, and it was cervical neck and low back was a diagnosis, different conditions. So we're treating those areas. And they come in, and on the imaging report is really impressive. The MRI for the lumbar spine was tremendous. It was like a book. And then for the cervical spine, there was a little arthritic change. Wasn't much going on, just a little bit of degenerative type stuff, right? And so I asked the patient, I said, my goodness, I mean, your low back must just be killing you. And she says, no, my low back is just, it gets a little sore, but honestly, my neck is killing me. And I have this tremendous pain in my neck, and I can't sleep, and I can't, if I raise my arms up, my neck hurts. If I turn my head, my neck hurts. Um, so that was just really interesting, when I thought this doesn't match. And then you start looking at a lot of this research and a lot of what the different experts are coming out with now. It's like, you may have 60% of people over the age of, 30 that have asymptomatic pathologies in the cervical spine or something. I'm just throwing numbers around, but there are those types of numbers out there with research that support that a lot of people just in everyday life have a lot of these things. You're not aware of it until something happens. Um, Another example of that with the imaging, I had a patient several years ago that was putting like a gas can, 5 gallons of gas, I think, was putting it in the back of his truck. Was going to work on his yard for some lawn work, and felt his back, pop, or it, quote unquote, went out. Had difficulty standing up and everything. And he goes to his doctor, and the doctor gave him a diagnosis of scoliosis. This is a 50 something year old male. late 50s, and he comes in and he says, "Well," he said, I know what's wrong. I just got to try to get it all worked out." And they told me to come to therapy and y'all would work that out. And I'm like, "Okay, well, what did they tell you?" And he says, "Well, they did x-rays and do an MRI, did x-rays, and they said I have scoliosis." And I thought, well, okay, you had scoliosis at 15 years old. I don't, I mean, has your back ever bothered you before? And he says, "No, and I've never had any trouble with it, until now." And so, what ended up happening, basically, we had, kind of some hot facet joints and irritated nerve roots from his position. Within about a week and a half, he was fine. I mean, completely resolved all the issues. And guess what? Scoliosis was still there. Um, so that was another good example. And I could go on and on. Over my career, there's been so many times. A lot of that is it has presented itself, and I think I don't even know. Oh, and this one I got to share this one. This is a good one. Um, had a patient several years ago. Woke up, had excruciating neck pain. This went on for about 2 weeks. Goes to the emergency room, and the emergency room physician gave her the handouts, gave her the papers, and then I brought those to me. Told her that she had torticollis of the neck. Now, if you're aware of what torticollis is, I asked her, I said, "Is this something that's bothered you your whole life? Since you were born or you were little or since you can remember?" She goes, "No, like 2 weeks ago, I don't know if I slept funny or what I did. I've been moving some stuff around and irritated my neck, and so it's been hurting since then." Well, guess what? Torticollis was not the right answer. I said, "You would have known." We worked on her, I think, about 2 weeks maybe between manual therapy and then exercises and a home program, and she did fine and no more issues. So again, that was just another example of, I don't know if it's just one of those situations someone doesn't know. You would think they would know, right? They're a physician, they should know. Or if it's a situation of just passing it off as, here you go. This is what's wrong with you. Even on the papers that were given, it's a picture of like an illustration of a baby with torticollis of the neck. So that was just very interesting to me. Um, so going over the imaging, obviously, is very, very important to me. I've done a lot of additional education and training on imaging, musculoskeletal imaging. And so going over that as best that I can. I'm not claiming to be a radiologist or anything like that, right? But just going over the things that I know that apply to my profession. And and then we're going to go through things that, what your pain is, what your pain isn't. In a lot of cases, you have mechanical pain and chemical pain, which you're going to have chemical pain, right, with the mechanical. It's kind of overlapping because the neurotransmitters, right, are sending the pain signal. But an example of mechanical pain is going to be you partially tear a tendon in your elbow, right? So that's mechanically, there's something there. It's going to show up on imaging. There it is. And the chemical pain would be 6 months later that is healed, but you're still having this elbow pain. Why are you still having elbow pain? If structurally it's healed, um, we're still getting that pain signal. There's still just a disruption in the pain signal to the brain. So that's when we're trying to break that cycle of that pain signal going to the brain. So that's going to be a chemical situation in that instance, and that typically happens with pain lasting longer than about 12 weeks, about 3 months. It's considered chronic. Um, and so that's when you're going to, that kind of changes. It can be more difficult because the brain is easily tricked, but it's not easily convinced. So you can trick the brain with TENS units and massage or joint manipulations or mobilizations, but a lot of times it won't last. That's why if you go to your chiropractor or maybe your osteopath or your therapist, whoever's doing that, and they do joint manipulations or joint mobilizations, feels really good. In a lot of cases, you improve range of motion, but it you typically have to go back and have that done again and then again and again, unless it's followed up at home with exercises or during the treatment session. You do this, then you go through stretches or range of motion or strengthening exercises. Then that's where you can kind of keep it. And my approach with a lot of manual therapy and modalities is you use those things when you're talking about pain. Now I know you can use them for other things as far as like retraining the brain for like biofeedback and all that, but when you're talking about for pain, then I use the modalities as kind of a way to open the window and then to climb through the window. So the window is you're opening up an opportunity to allow for some movement, to occur, strengthening to occur, and that's when you're going to make the real gains or the real improvements. Is those strengthening and endurance exercises and functional mobility training or functional training type things. So that's what you want to do. So I use the modalities in the manual therapy for those aspects. And if you um, massage and kind of desensitize the area. And that's the other thing when you come in. So we're going over the imaging, and then it's very difficult. If I said to you, if you come in with shoulder pain, and it's a very painful shoulder, been painful for a while, and I said, okay, we're going to do the back and start rotator cuff exercises or whatever. Yeah, you're probably going to say that's not going to happen. Or neck pain, and you kind of have a mild headache, and I said we're going to go do some neck strengthening exercises. Not going to happen. You're not going to like it. If you tolerate through it the first time, you're probably not coming back because it really flares things up and increases the pain. So I like to go more, first few visits, more passive, more kind of feel good, relax everything out. Maybe it's heat, massage, stretches, go over your home movement program. I usually like to give 1 to 3 things. Usually one, thing that I want you to do at home, regardless of your diagnosis. You typically are going to get at least one thing. I may go up to three. I don't like to go over three because for home programs because nobody likes to go home and do a whole bunch of stuff. Right? It's in 20 years, 21 years, whatever I've been doing this. Nobody wants to go home with this massive booklet, a home program. Just don't want to do it, and I get that. Um, but I do really encourage patients to do the little bit that I do send them home with, or our staff sends them home with. I think that's important to kind of keep your gains and your movement, your progress that you're having. Because what we want to do is maybe my approach is you're starting with pain issues. You're starting passive, right? We're starting with some passive things, and then pretty quickly I want to get into active and passive combo. So we're doing exercises, self stretches, self management techniques. Learn how to adapt different things at home and your movements. Um, Definitely have to do your home program. A simple program, but I want you to do that. And then we'll continue with the modalities and the manual therapy stuff for different reasons to try to modulate your pain, to improve kinesthetic awareness to the tissue and the joints and joint mobilization, try to improve your range of motion, all these things. And also, I use a lot of the modalities of feel good stuff, right? The electric stim and heat and all those kind of things, also as kind of a bargaining chip in a way. Like if you can go through and do these exercises, then we'll do this feel good stuff at the end. Or if I'm going to do it beforehand, I'm going to do that to prep the area. So I'm going to do that to kind of prime the area for the movements that we're going to do. So, um, just it just makes a more productive session, I think. So whether you're doing those modalities and manual therapy beforehand, or whether you're doing it at the end, either way, both can be very effective and beneficial. It's just your preference, honestly. It's kind of what you're trying to do. So that's my approach to pain. I'm looking at it. I'm going over or pain with my patients. I'm going over the imaging. Make sure you understand that your diagnosis. Let's go over that. Let's discuss all of that. And then let's discuss our treatment plan, the kind of things that we're going to do. We're going to ease into things. I think that's important. And then from there, we just reevaluate and see how things are going. I think the biggest thing to do in the whole process of this is to reassure the patient that this is not in some cases not a simple fix. I mean, it is, but it isn't. I mean, it may take a little time. You've been suffering with pain for 10 years with your back or your hip or your elbow or whatever that is. um, don't always expect it to be resolved in 1 or 2 sessions, right? It's going to take some time. We have to relearn some things and retrain some areas of the brain. And when you do that, then you can have a real change. And so I always tell people, you be a little patient as much as you can, right? Because I know coming in, you've been suffering with it for years and you're ready for it to be resolved. So just be a little patient. And a lot of times it does really well. So I think that's a good approach versus you're going to come in and do these, wall presses or prone press ups, 3 sets of 15, or you're going to go in and do these band exercises for your shoulder, or you're going to go straight to the leg extension machine. Uh, a lot of that doesn't work. We have to get the buy in. We have to get the assurance that the goal is to not flare things up too much. It may flare up a little at first, and that's part of that reassurance. Let them know it's going to flare up some. That's okay. But at the end of the day, we want to resolve your issues, and that's the path to resolution. Sometimes it's some discomfort, some exacerbation of symptoms, but just be aware in the long run and at the end of the day, we want to resolve these issues so you're not dependent on me. And that's the final transition to that active. So we get passive active kind of together overlapping, and then it's an active situation where you're able to manage any symptoms that keep coming up, or your current symptoms if we get them down to maybe your 95% to manage that other 5%, just to try to teach the patient how to not be dependent on therapy or whatever healthcare provider that is forever, because that's not the goal. We weren't designed for that. weren't designed to need somebody constantly. You should be able to do it on your own. So I hope this video helps go over, my approach to pain with patients. I think I'm not saying it's the best way, but it definitely in the past works for me really well because I went, the ways of all passive kind of stuff. And I went very aggressive and straight into movement and exercises. I don't think that works because I think that, going at it kind of easy at first, kind of like making friends with someone, right? You be really nice at first. Not saying you shouldn't be really nice the whole time, but you have to definitely be nice and inviting and welcoming. And then your relationship kind of develops from there. So, kind of the same thing. Thanks so much for listening, guys. If you're on YouTube, thanks so much for watching. I appreciate all the tremendous support you guys have given me on my podcast, on my YouTube channel, all my social media. It's just really incredible how fast everything has grown for me. I appreciate you so much, and I will see you guys next time. Thanks again.